So thank you for attending today. My name is Nancy Joyner. I'm a palliative care clinical nurse specialist. I've been a nurse now for 41 years, believe it or not. And really, this is one of my most passionate things is about the conversations that we have in palliative care. I have the privilege of working for the Center for Rural Health as their outreach specialist with subject matter expert in palliative care. And this past year, I have also the privilege of learning and being more formally educated through the serious illness program through Ariadne Labs as one of their ambassadors, and have learned a lot. So this is very, like I said, a very passionate area for me. There we go. So I have 3 objectives I'm hoping that you will really get it today, is really be able to see the benefit of high quality earlier. It always seems too early until it's too late. Serious illness conversations with patients and families, because we're always the elephant in the room. Nobody wants to talk about this stuff. And I want to identify some of the steps involved in these conversations. You know, it isn't just jump in there and take it away, and use some of the best ways for using an actual serious illness conversation guide. There are many out there. Vital Talks has one that's very similar, but I'm going to be using the serious illness conversation guide today for this. Advanced care planning, most people think right away of the healthcare directive, and it truly is a process and a continuum where we have conversations going on. We should start by the time we're 18. You know, if something happened to you tonight, what if, you know, the who and what would you want? So when people are healthy, very independent, throughout the whole course of our life, we want to maintain and maximize health and independence. As we develop more serious illnesses and chronic disease, our function will change, our ability to reason changes, we have more comorbidities, but most people want to have that nearing end of life with dignity, and we don't always do it that way. We don't always honor what people's wishes are. So we have found that there have been, Sean Morrison did an article, and at first we were a little concerned because he talked about all these flaws, but he also gave recommendations on how to improve them, because we can't envision every situation is going to happen. So the important thing is having those conversations with the healthcare agent so that they are aware of what's going on. The problem is that patients don't communicate with their healthcare agent. And so we try to figure out what is it that somebody wants and try to guess and speculate from that perspective, which doesn't always work well. And we have a lot of lay advanced care planning programs, but we don't have anybody that's really facilitated for this. Then we get to the problem that preferences are not acted upon. We have the PULSE program and things that help to guide that, to translate people's wishes into medical orders, but not all those are always taken care of. And a lot of times these healthcare directives are not accessible. We don't know where they are. People actually lock them in their safety deposit boxes. They haven't been touched for 5, 10, 20 years, and they're not always PULSE appropriate. These people aren't necessarily nearing the end of life. So we have this large perspective and large continuum of people longitudinally that we have to do that, because preferences change over time. It's much different if you're 18 years old than if you're 98 years old. So providers don't know how to have these conversations, and it truly is a medical-based thing we need to do. So the serious illness conversation guide is truly a very valuable tool for doing this. Now, when we think about our own mortality, which nobody ever wants to do, most of us want to be up in the upper left corner where we're going along and all of a sudden something happens to us very quickly. You know, an unexpected cause happens. This is the heart attack, the MI, something happens very quickly. Most people think, oh, you want to die in your sleep, but then people are fearful to go to sleep in the fact that something might change that way as well too. The second one on the top, on the right side, is what Medicare came up with, the hospice benefit. If the disease ran its natural course, similar to cancer, which was the original one back in the 1980s, you see this decline, and over time that you would expect that. These two are not very realistic for most of us to be able to do that. The bottom two are what we're seeing most of the time. So when we're seeing people with chronic illnesses or serious illness, they go along and then they have something that takes them down, but they never get quite back up to that baseline. And then the next one is is the dwindles, I call it the frail, where it's just a very slow, steady deterioration, not knowing exactly when we're nearing the end of life for that. The newest trajectory, though, is similar to what we have with COVID, where it's a catastrophic event, where something happens very quickly, your function is fine, and then all of a sudden you decline, and it might be like the first one where it happens, but it might detain and last a little bit longer. But this is another one that we have to look at. So we're never knowing where somebody is along this whole perspective of where it is. I love this definition of serious illness. It's a condition that carries a high risk of mortality, which most of us know, and either negatively impacts a person's function or quality of life, or excessively strains the caregiver. So it's that and we have to pay attention to. It isn't just about the disease, it's about what is it doing to the individual and the caregivers taking care of them. Problem is that most physicians don't have the experience, the time, and aren't comfortable with discussing progressive debilitating illnesses and issues that are there. And it does take time. So it's not only to have like a prognosis diagnosis component of it, but all the other what ifs and what makes us whole. You know, the fact is that only 10 to 20% of us really are thinking mostly about our physical and health in a general. We have all the other issues of day to day that are going on. So the more we learn about this and prepare for the discussions, the more skilled we're going to be to do it. Practice makes perfect, especially when it comes to conversations. When we have totally the ideas of goals of care, we want to really focus in. It's not about us. It is about the people we're taking care of, our patients, our residents, you know, those people. And we need to talk about goals of care planning. And people don't like that. That's a really hard one. We have to have code level discussions. We have to talk about pulse. And we have a whole education about pulse that I would encourage you both through Project ECHO and through Artery Traces North Dakota for attendance to learn more about, but I'll bringing that up more. And then do people want to know about the rate of resuscitation, you know, where it's going? And does the healthcare directive affect them where they are now, or is it only when they're not able to speak for themselves when they think the disease has progressed? So future care is that whole advanced care planning idea. And so we look at the current for goals of care now, and then decision-making and consent discussions for the future. The treatment and care decisions can be made. So it's information about past, present, and future that we really, really have to look at the full picture. But why? What matters most. You know, we know about the triple aim and the quadruple aim, but for older adults specifically, there's going to be lots of variation. If you talk to one older adult to another one, you're going to see such variations that it's not going to be the same. Basically, they for sure want to be more engaged. They want to be listened to. Storytelling is the biggest thing that people need to do. And they often want to avoid unwanted treatments while receiving those cares that do make them comfortable. And comfort cares only, not just only, you know, to always provide that we get confused with that when we say comfort cares only, but we always should be kept comfortable for people. I don't think anybody attending today would disagree with that. In our health systems, we know that we want to have things that they don't want eliminated, but have the best experiences for them and quality assurance that we can. But for everyone, we want everyone on the same page. And the only way to do that is to have good communication going on. So improving our relationships, developing that trust and relationship that's there, it's the basis for everything else. So communication, conversations, discussions need to occur all the time. We also have to include the culturally appropriate parts of this conversation, you know, preferred terms. I have learned just even use the word pain from gender to age to all the different dynamics of cultural differences, the diverse things that go along with that. And the appropriate degree of formality, you know, how to address things. Is this appropriate time? How do we do this? Do we do it in bits and pieces? What makes sense to them? And definitely to include an interpreter if the materials are from a non-English speaking. So it's very important to do that, but also to include the nonverbal components of that. The biggest things we're finding is from Western culture and other things, that lack of trust and fear that goes along with it. So that we really have to be careful and be aware of that. And the history of trauma and violence, the survivors of racism, it's a very sensitive type thing. And especially if you're talking about their future health, are you going to, we don't want them to be thinking like we're the death panel or trying to influence them. We want to give them choices and make sure that they understand what we're talking about, risk, benefits, burdens, and expected outcomes in terms that make sense to them and that they want to hear. Sometimes they do refer us to somebody else instead to be able to bring that across. And then to really recognize health beliefs and alternative therapies along with complementary therapies. Not everything follows exactly Western medicine. If you ever stand in any kind of a pharmaceutical area of a store, from Walmart to CVS or Walgreens or whatever, and you watch how many people choose herbals and vitamins and supplements and things, they're basing it on either what other people have said or what they've seen on social media, et cetera, to bring to them what they think is going to be best. But the big ones are to consider decision-making factors and that individual autonomy. Who is it that makes decisions? So frequently I'll hear people say that they want me to refer to their healthcare directive and talk to their family, or whatever my family says, that's what we're going to do. And it's really, really important that we focus on what matters. It may not matter to us, but it matters to them. When we're talking about goals of care and treatment options, we are often not in the position of talking prognosis, but who are we going to get involved with? And these are some really very good, valid questions that we find that are helpful. What is the one thing about your healthcare that you want to focus on most so that we can do it more easily or more often for you? And it's very interesting on what we think of for health might not be what somebody else is thinking about or seeing. What are your most important goals now? And as you think about the future with your health, what concerns you most when you think about your health and healthcare in the future? And concerns and fears and worries. Again, on that next question, what are your fears or concerns? Some people are offset by those words alone because of the negative connotation, like something is wrong, doom and gloom, and you're actually bringing it, putting it out in the universe, the destiny, bringing it to them. So you have to kind of sway and feel it out a little bit. And then what are your most important goals if your health situation worsens? Now that's a hard one to get around. What things about your healthcare do you think aren't helping you and you find too bothersome or difficult? Remembering that medications and everything that we're doing is a health industry. It's, they're consumers. And so we have to find the give and take of what works the best. The big one I really like is this next one. Is there anyone who should be part of this conversation with us? And sometimes they say, I want certain people excluded, and you have to make sure to include that in your plan of care as well too. So advanced care planning is across the whole perspective from the time, like I said, people can make that decision. So we have the traditional, the what ifs, the who, all of that. But serious illness conversations really, really fit in as that bridge before we get to the really high critical components. So increasing chronic illness, hospitalizations, crisis, we want to stay away from sitting down in a quiet room or in an intensive care unit to start these for the first time. So the earlier you have it, I call it upstream, the better you're going to have for this whole umbrella of advanced care planning. Our resource people are very important to point out, that it isn't just the physician who's waiting for someone else to bring it up. In fact, they appreciate that. So nurses and social workers and chaplains and supervisors, palliative care team. I'll never forget, I was on the floor at All True Hospital. I'm here in Grand Forks. And one of the housekeepers came and said, Nancy, person in this room needs you to talk to them. I'm like, oh, okay, an interesting way to get a referral. But, it's interesting where people will divulge things or share more in where they feel less threatened with other people that are in the room. But you want to provide them with information about healthcare directives for those who wish to have more information. And some people are visual. Some people love like a video and listening very well. Some people need written. I try to provide everything that I can, every kind of resource, what works best. and do it in little bits and pieces, because it's going to assist them in completing it in the future, but you have to have those conversations way ahead of time. There are other staff that are not designated to do healthcare directives, but they can help us with that. And I want you to look at the little diagram over on the right-hand side, because so many people don't know our default process here. So when we are healthy, by default, our standard of care is do everything, right? Our Good Samaritan Act, our everything, by default, we will be full code, attempt CPR, etc., for anybody that's healthy, or unless we have some kind of documentation. Then we get into legal documents that say, if I'm in this circumstance and if I can't make decisions for myself, then this is what I want. And then the least healthy are when we translate those into medical orders, such as post orders and things like that, when we really are definitive that we don't want to go back to the do everything, that we want to have more control over the things that we do. I'm always looking for ways to and tools to get us started. And one of my absolute favorite is called Go Wish. I actually have this, I think, but there is a deck of cards called Go Wish Game. I'm going to show you a little bit of the variation. So again, these are
not dying alone.
At least you're hearing them.
To feel that my life is complete. Wild card.
And my wild card, in my case, I love animals. So having my animals around would be important. And you can actually write it on the card. But again, you can see that you put them in this order. With the card, I did a 4-generation family. I had a 9-year-old, her mother, grandmother, and I was taking care of the great-grandmother. Now, I was very surprised that the 9-year-old was the first one done and really had a good handle on this. And the mother and the grandmother, great-grandmother really got it, but the other two were very concerned, like, is this too morbid for her? And, you know, making those kind of comments along the way. But actually, it was a great conversation that came up.
To be able to talk about what death means, to trust my doctor, to have my financial affairs in order, to die at home, to keep my sense of humor.
That one would be one of mine.
To meet with clergy or a chaplain.
Okay, so there are several that are going to be up here that are related to spirituality, religion, etc. And I have a sister that's a very devout Catholic. And when we did this game, she put every one of these cards down in the not so important area. And I'm going, hold on. I know that this is very, very important to you. What are you telling me? You know, why have you moved them down here? She said 2 things. Number one, you already know that about me. And you only give me 10 spots for very important for us to talk about. So again, you know, how the dialogue makes such a big difference for people.
To say goodbye to important people in my life. To have my family with me. To be able to help others. To have close friends near. To be free from anxiety. To be treated the way I want. Not being short of breath.
This is a hard one for a lot of people.
To pray. To remember personal accomplishments.
Next book so this is a great game. And again, it's free. And I don't have any financial or any, I have nothing to do with the group that make these cards and stuff, but I just really like them. Another one in this category is called Hello, Common Practice. And then this Hard Choices for Loving People by Hank Dunn. He is a chaplain and he writes about CPR and all these kind of really great conversations, artificial feeding, dialysis, palliative care, hospice, even brings up pulse now in the 6th edition. And the patient with a life-threatening illness. And it's very neutral value. It's not influential. It's not guiding anybody as far as prognosis or anything, but it just has different things that we have for that. The serious illness care resources are here. And then the conversation project starter kits are amazing. I'm going to see if I can open this. Okay, I'll stop sharing. Change it again. Okay, where did we go? Is it showing on screen 2? Sorry for the flip-flop. Okay, so are you seeing it now, the conversation project? This is just a great, great way, again, free things for here. They have guides for just the general part of it, how to choose the healthcare agent. And a lot of people think by law, they have to choose their husband or their eldest child or et cetera. But this is the things, like what if they're put in a time of crisis? How are they going to make some of these decisions and thoughts that go along the way? And then here is the guide to being one. I have several times been into a situation where they haven't been able to have the person who was supposed to be the healthcare agent contacted. They went to the next of kin. Nobody saw the actual healthcare directive, and they chose the person because they live locally, but the person didn't even know they were the choice. And then a guide to how to talk to your healthcare team. Someone has to start this conversation. This is an excellent What Matters to Me workbook. Highly recommend this one. And then for people with Alzheimer's and other forms of dementia, and then care for the child. And here's one specifically for being in a time of COVID. So the Conversation Project is an excellent, excellent site for that. All right, the National Healthcare Decisions Day, April 16th, is another one that really helps to give people guidance on how to have these conversations, both from the layperson to us as professionals. And many people don't know there's an app. There's an actual app called My Directives that is available, and you can print it. In most states, you cannot use a video as a healthcare directive, but you have to have something in writing. In the My Directives, you give the contact information to your healthcare agent and then your primary physician. They can print it and boom, it's ready to go. I also want to say for our state of North Dakota, we have Honoring Choices North Dakota. And we have all kinds of resources here. Our healthcare directives, we have two that you can print at any given time. One is a short form and one is a long form. We have notarization that's on here. On the short form, this is recommended for, are you still seeing the screen okay then for everybody? This is that showing the appointment of the who and a little bit about what you might want, and then you get it signed. And so this is suggested for people that are between the ages of 18 and 40 without healthcare issues. The longer form, of course, gets into many other topics. I'm going to quickly show you this one. And so it goes through, what you want for your powers of your healthcare person and how much you want them to do. What do you want about CPR, your treatment choices, prolonging your life decision, organ donation is here, autopsy, comments on your directions. But this is the part, and it says it's optional. And I really wish it would be the first part. I want my loved ones to know the following thoughts and feelings about me, the things that make my life worth living, my beliefs, my thoughts, my feelings, where I would like to die. If I'm nearing the death, these are the things I would want, appreciate, etc. Again, legal authority, Notary Public, if you have that statement of witness. And in North Dakota, we do require that they accept the appointment of being the healthcare power of attorney. And here are for the other states, if you're in other states as well too. Okay, so this is just things to get us started, to be thinking about, but this is the guide. And I truly, truly love the guide. We've actually added a few more things. However, the Ariadne Lab said, make it a second conversation so that they don't think that you're influencing them at all. So it says, introduce the purpose. Oopsie. I'd like to talk to you about what is ahead with your illness and do some thinking in advance about what is important so that that I can make sure that we provide you with the care you want. Is this okay? You have to ask permission. And so many times we don't do that. If they're not ready, that's that loss of choice and control. So it's so important that, is it okay? Then the next one is, what is your understanding now of where you are with the illness? And trust me, oh my gosh, in my 40 plus years of being a nurse, how many times they are here and the healthcare team's way out here. And so to make sure that they do have some information about that. And then how much information about it ahead for you would you like from me or from your healthcare director? And I carry this in with me. So I actually have the sheet and write notes to myself. If I don't have the answers, or if it's outside of my scope of practice, I'll say, here, let's take some notes for your doctors. Because the next section is the prognosis. And most of us don't have any way, but you can do a wish or worry, hope or worry. And you can talk about uncertainties and you can talk about function. Time-wise, no. We don't know how much time anybody has, but I want you to understand my understanding of where things are. It can be difficult to predict what will happen with your illness. I hope you will continue to live well, but I'm worried that you could get sick quickly. I think it's important for us to prepare. Or the function, I hope that this is not the case, but I'm worried, or concerned that you may not be as strong and things may likely get more difficult. So sometimes planting that seed just a little bit, and you may be wrong, but how much most people would rather be prepared a little bit and be proven wrong than to not have that. And then you want to explore key topics. What are your most important goals? This is an important thing. So you set it up, and that's the other thing. You don't have a conversation in a hallway, and hopefully not very often in a quiet room in an intensive care unit. It's best in the community, at the sitting down at their own table. If you can do it in the clinic, that's great. But find that place that they're most comfortable with it. Introducing the purpose, etc. Now getting down to the goals, like I said. What are most important for you? What are your biggest concerns? Again, fears and worries, you have to, after you find out a little bit more about them and develop that trust about the future with your health. What gives you strength? What abilities are so critical to your life you can't imagine living without? If you become sicker, how much are you willing to go through for the possibility of gaining more time? Because so many people think they're going to get back to their baseline. And so we have to talk about that. And how much does your family know about your priorities and wishes and even your health condition? So a lot of things that go along with that. So the critical abilities, trade-offs, and family. Closing is very important. You want to summarize and make recommendations for that, check in with them, and then affirm commitment to it. So I've heard you say that such and such is very important to you. Keep in mind, and you can literally use these words or change them to do any way that you want to. I recommend that we talk with your doctor and make a plan. This will help us make sure that your treatment plans reflect what is important to you. How does this sound? I will do everything I can to help you get through this. And that's such an important thing, that support in any way that you can. Very important to document it in whatever way you can and communicate with every key clinician that you have. So this is a very, very big piece of what's important. Serious illness, the program itself has a 3-hour practice this. So they actually go through this and then practice with actual patients, which is amazing because they're going to give you responses and you're not like, whoa, you're not quite there with what kind of things are going to do that. I'm going to see if we can do just a little bit of it for us. Are we seeing that right now? Are you seeing the screen? Okay. And that's not the one I wanted. I wanted the actual video. Should be here. Nope. Okay. How am I doing time? I'm going to come back to this if we have time. But they have an actual video of showing the conversation in action. What about the prognosis thing? And this is the hard one. None of us know, but so many family will say how much time or what should we be looking for? Or should I come home now? Or what are these kind of things? This little booklet is called the Blue Book. It's known nationally. Many hospices have their own, but Gone From My Sight by Barbara Carnes. She's a hospice nurse. She wrote this in 1986. It's only like 12 pages long, but she goes through what to expect, minutes, hours, days, weeks, and months before nearing somebody's end of life. She talks about the surge of energy. She talks about talking to people that have died previously, so many different things that helps to prepare that these are normal processes, the loss of appetite, the not as active, so many things preparing people, but you don't have to be telling them an actual prognosis. One of the things I really like whenever I do a booklet is that I do talk to them and say, I have a booklet that explains, kind of hold it out. If they don't take it, I set it down. Some people are not ready to look at this information. And you'll know kind of the timing for it. Some patients actually want to see these things as well too. So bringing up prognosis, again, this is not in our scope. So this is a great one just to say, this one might tell you a little bit about what you may expect and going through some of those things as well too. Translating patients' wishes into medical orders is such an important thing, honoring the wishes of those who are frail and doing that with hope. So this is part of our Pulse program. This is from the National Pulse. And they talk about Pulse, really, it has different names, et cetera, but it helps to translate what those wishes are into medical orders, something that an EMS can respond to. And just like you would for a surgical consent or anything like that. So it communicates the wishes and medical orders. And I really like this little video, so I want to show you this little video.
When we have a serious illness, it is natural to fight to get better. Having hope is something that gives us strength. Over time, as an illness changes, what we hope and fight for can also change. When we have a serious illness like cancer, it is natural to hope the treatment will work and to fight to be cured. For some, this is possible, but for others, this is not possible. When a cure is not going to happen, we can continue to fight for what is possible. After a while, however, if there is not a cure, and living a long time is not possible, it doesn't mean we should give up. We may have a bucket list and try to do as many things as possible. Our focus changes. We might fight to do things we love or to be with our family as much as possible in the time we have. Most of us want to be pain-free and have a good quality of life. Some of us hope for closure with those we love. Sometimes we just want to have the time and chance to say thank you, forgive me, I forgive you, or I love you. Or to talk with a spiritual advisor. When the time comes, most of us want to have as meaningful and comfortable a death as possible. It's important to talk with your family and healthcare team to make sure that happens. Wherever we are, we do not have to lose hope or stop fighting. Making this shift can often help us find peace within ourselves and with those we love. We may not be able to change how much time we have, but we can choose how we're going to spend it. Talk to us about your goals, and we can help you make a plan for what is important to you.
Really like that video clip. It just kind of, ties into how important it is for us to be looking at the future and being a little bit prepared for that as well too. So that's our National Pulse site. I wanted to do a case study here. So Jane is a 77-year-old lady with stage 4 cancer. She's on chemotherapy. She comes to the emergency department at 1 o'clock in the morning with a perforated bowel. Surgery is consulted. Nothing's been documented whatsoever on any kind of conversations for the what ifs. And surgery needs to have an informed consent about the discussion with her, the what ifs, etc. So these are some of the things that we thought, what would make conversation about these treatment options easier for the surgeon. Not help, etc. Earlier, yes. At this time, very, very difficult to have it. So she's alert, competent, and understands the gravity of this illness. But she's in distress, and if she's delirious, now her proxy becomes present. Now what do we do? This person needs to have an informed consent, but there's no documentation whatsoever. So documentation, if you didn't document, you didn't do it kind of thing. So we have to have that documentation of any kind of serious illness conversation, and earlier than later. And it doesn't always have to come from the physician or the primary care team. It can be from other people as well too. So I've mentioned POST a few times, and this is our North Dakota POST form. This is the front page of it. It's a medical order. It's signed by the patient or an agent, and then it needs to be signed also by the physician or advanced practice provider. I'm a advanced practice with prescriptive, so I can sign these. And I've actually done them in homes with people, which is really, really a nice situation, you know, with family present, etc. It's portable, and the original always stays with them. You can make copies, and it moves with them, and it may change over time, just like for any other order that comes along. So it addresses the CPR, and we use words like attempt CPR or allow natural death, you know, instead of DNR, do not. That sounds pretty negative if you really think about it, but that's been our, you know, we've used that code status for years and years. And many places still in North Dakota use code 1, code 2, etc. And this is a great way to transition over to utilizing the words that EMS also understand. And this is accepted by statewide EMS. So medical, but we still are working on the awareness and education about it. So just keep that in mind too, but it is accepted and approved. But then the next goes into what, and CPR is a totally different thing than if somebody wants something else. So again, I want you to come for the full training and how to script and talk about this one, but I just wanted to let you see, you know, that's why we keep it separate, because a person can allow natural death, but still have full treatment. You know, it's only if your heart stops and you're not breathing, you've died, that you allow that natural death to occur. So there are different levels there. About artificially administered fluid nutrition, we also worked with our Catholic diocese to include the non-beneficial statement, the artificial nutrition and hydration, unless it provides no benefit. They have moved from ordinary, extraordinary to beneficial, non-beneficial, which is also there. They also places for additional orders, just like any other kind of consent form. Who was it discussed with? You know, who was the legal representative at this point in time? And then the physician signing it into a medical order. So again, just as a quick overview of what it is. So where does it fit in? It's not for everybody. I've talked about conversations along the left here, and advanced directive is at age 18. And then updating that advanced directive, the American Bar Association says that you should be having these serious illness conversations and looking at a healthcare directive, the 5 Ds, every decade of your life. So by the time you're 18, you know, I'd love to see this in life skills class, that we have this, not only the financial will, but we talk about healthcare wills and stuff as well. But every decade of your life, every time you get a new disease or diagnosis, anytime that you have a divorce or change in your family, and then any kind of new disease or diagnosis, and then death, any new death experience, personally or professionally, but everyone waits for the last D, decline in status. And so it's such an important thing that we do it much earlier. Then if you do get, you know, if you're crossing, if you remember that rainbow that I had earlier, and that you have a progressive illness at any age. And I actually did a pulse form with a family with a 2-week-old incompatible with life. It was very, very hard. And 109 is the oldest person I've taken care of. So then we had the conversations and we talked about it, and pulse can change over time, but we completed it. The ultimate goal for all of advanced care planning continuum is to honor the treatment wishes of the person we're taking care of. So I wanted to wrap up this part of it and really give some time for Q&A. And if we have time, I'll show you this video clip of an actual conversation that occurred through the serious illness conversation. But we want to provide high quality, earlier serious illness conversation. It's a responsibility of all of us. So using like the serious illness conversation guide and completing healthcare directives and pulse forms after facilitated comprehensive conversation, because the ultimate thing is it's going to have the better goal concordant with the care that we're going to provide in treatment, but patients and families will have more time to plan and complete what is unfinished. It is a gift, and we often forget that, you know, how important it is. So my challenge to you is, how many of you are over 18? That's what my next question is going to be. You'll never guess, right, with what it is. And I have several references here. that
So my name's Chris from Nelson County Health Systems, and we're kind of working on getting the palliative unit set up here. Do you have a contact information that we can get a hold of you, which is kind of more detailed questions in the program?
absolutely. You can, if you actually Google me online, you'll find me everywhere. But Nancy.Joyner@und.edu is probably the easiest way to find me right away. I'm through Honoring Choices. You'll find me on that site. You'll find me in many different places. But yes, we're more than happy to do this. We're very excited about getting it out. And one of our big things is the serious illness conversation. They're having the advanced care planning. That should be everywhere. And it's everybody's responsibility more than anything. And we're not doing the best job we're doing yet. So
Does a palliative unit, say in like a hospital setting, does that require a certification?
no.
Or you can
No,
just kind of,
Are you talking a unit? Are you talking like hospice and palliative care, or what are you thinking of?
like within a rural hospital, can you create a couple beds for palliative care?
People have done that before, yes.
And
So
that doesn't require any additional licensure. It's just something that you can
no, because
incorporate into
people
care.
exactly, because people move in and out of it. It's, you know, like if you have an orthopedic unit, or if you have, you know, these other kind of things that go along with it. So much different than like a critical care unit, et cetera, with that. So I applaud you for that. I'm so excited.
It's good to see you, Steve.
Doc, it's good to see you. Yeah, it's a pleasure.
I know that you were in the hospital last month.
Yeah. Well, you know, it was another one. You know, but it's fine. I'm out now. I'm doing better.
Yeah, I'm glad to hear you're doing better.
Oh, yeah.
I was hoping that we could take a step back today and talk about where things are with your illness and where they might be going. Would that be okay?
But I'm doing fine. You know, I'm doing okay now. I don't see why we gotta have a big conversation. I thought we were just gonna talk about my meds and kick me back out on the street.
It's really important to talk about your meds, and we're definitely going to talk about that. But I do this with all of my patients because it helps me understand what's most important to you so that you can have as much control as possible over your medical decisions. And I'm going to use this conversation guide just to make sure that we don't miss anything. Is that all right?
Sure. Yeah.
Okay. So I'm just going to start by asking, what's your understanding now of where you are with your illness?
I don't know. To be honest, I got a lot wrong with me. I mean, I got my kidneys, I got my lungs, I got my hip, I got my knees. It's been, you know, especially the past year, it's been tough.
Yeah.
But, you know, I'm confident that I'm a positive guy. Mm-hmm. And I stay positive. Mm-hmm. I work day to day, and I make sure that I get through this.
Yeah.
That's how I do things.
And your strength and your positivity has been really remarkable through this whole process. I just wanted to tell you that.
Thank you.
So in thinking about the future, how much information about what's likely to be ahead would you like from me?
I should know everything that you, I mean, I should know everything. Yeah. Just, you know, keep the medical terms to a minimum because they cloud my head.
I also hope that you can keep getting through this. But I'm worried that because of the recent hospitalizations and because it's been getting harder for you to do things you used to do at home, I'm worried that this may be as strong as you feel and that your illness may worsen and it may get harder to manage at home.
Wasn't expecting that.
This isn't what you were hoping to hear, and it's not what I was hoping to have to say.
So what are you saying?
I hope that you can keep maintaining like this for some years. But I'm worried that something could happen quickly and that we need to be prepared in case things don't go as we hope.
Yeah. Yeah. I think that's a good idea.
This is really hard to hear. Say more about what you're thinking.
I'm just thinking about my family, my wife and my little girl. It's gonna break their hearts.
I know how important they are to you.
They're everything to me.
And so what we're talking about today is, you can think of it as a plan B. So
Plan B's are good.
we'll stay on track. We're going to hope that you keep maintaining, but it's important to talk about a plan B so that we can be prepared, you and your family, for future changes.
I like Plan B's.
So if your health situation were to worsen, Steve, what are your most important goals? What's most important to you?
Well, being there for my family. You know, my wife she's not a youngster anymore, and I gotta make sure that she's taken care of financially. I gotta make sure that she's taken care of physically. Mm-hmm. My daughter's 28 now. She doesn't have anybody special, but I mean, one of the things that I've always looked forward to doing is walking her down the aisle. So if you could keep me around long enough for that, Doc, I'd appreciate it.
We're going to keep hoping for that. We're going to work toward that goal. Okay?
Thank you. Thank you.
So it sounds like you have long-term goals, being there for your daughter, to walk her down the aisle, and some short-term goals, being around for your family, being present for them, being with them. Does that sound right?
Yeah. Yeah.
And what are your fears and worries about the future with your health?
Well, I'm afraid of being helpless. I'm afraid of being weak. I've always been the strong one in my family, and these hospitalizations have been really hard. It's been hard for my wife to get down here. My daughter feels like she has to drop everything. She has a busy life, and she has to come down and look after her daddy, and I don't like that.
So it sounds like having your family come into the hospital can be hard sometimes.
Very hard.
And you worry about your family and their well-being through this.
Yeah.
Is that right? And what, I think you've talked about some of this already, but what gives you strength as you think about the future?
You know, my wife and my daughter are the center of my life, and I mean, what gives me strength is when my daughter comes over for Sunday dinner, and in the summertime, we usually have time to take a little walk down to the park, and she brings her dog, and I sit on the bench and watch her play with my daughter, and that gives me strength.
And what abilities are so critical to your life that you can't imagine living without them?
I think, you know, I need to be able to speak. I made my living off my gift of gab, and that's the most important thing to me. But maybe just as important as being able to eat.
Yeah.
We've always been kind of a foodie family, so that eating and speaking. I think I can get away with, you know, I've gotten used to not being able to walk around much. I never was a very sporty guy, so, you know, as long as I can make it to the bathroom on my own, I think I'm okay.
So it sounds like sharing a meal with your family, being able to communicate with them, that's really important to your quality of life.
Yeah.
And if you were to become sicker, how How much are you willing to go through for the possibility of gaining more time?
Well, you know me, I've been willing to do anything that you throw at me as long as it's a short-term thing. I don't want any, I don't want to be, I'm used to the hospital now. I feel like I'm a veteran. I can go in and I can get out. I've been in rehab. They've been short, which is good. I don't like rehab. So I guess anything you got that's a short-term treatment, bring it on. But if it's something where I'm going to be stuck in the hospital for weeks on end, it's not for me.
Yeah. So it sounds like if we think we can turn things around so that you can go back to your life, your quality of life that is most important to you, you would consider things like hospitalizations and other treatments
Absolutely.
or procedures. But if we're ever worried that we can't turn things around, it might be, you might not make that same decision.
Yeah.
Does that sound right?
Yeah, I might not want to do that.
Yeah. And how much does your wife and daughter know about your priorities and wishes? What you just shared with me.
Well, I think she knows what I know. But of course, I wasn't expecting what you had to say today, so she may not know that. And as far as my daughter's concerned, I would rather that, I know she likes to know what's going on with Daddy, and I know she's got in touch with you. But listen, I would appreciate it if she does, if you just tell her that Daddy is fine. Okay?
Yes. You're in the driver's seat here, so yes, I will do that.
Thank you.
At the same time, what I've heard, the theme that I've heard through all of this is being strong and supporting your family. And that's really important. So I think there's a lot you can do to prepare your wife and your daughter for the possibility of future changes in your health. And some of what you shared with me today would be very helpful and important for them to know. And so my recommendation would be for us to meet, have an appointment together. We can talk about some of these things again. And we can also involve our social worker who can help, because these conversations can be hard.
Yeah, I'd appreciate that.
How does that sound?
That sounds good.
Yeah.
Sounds good. I mean, when I talk to my wife, like I said, I try to be really positive about it, and sometimes maybe some of the details might get lost.
And I think that that's very normal and completely understandable. And I think that we, when we come back together, we can talk about as much or as little as you'd like.
Okay.
Whatever you're most comfortable with.
Thank you, Doctor.
I just want to say that I'm going to be with you through all of this, every step of the way, with you and your wife and your daughter. And that I know that this conversation was hard and emotional. And I just wanted to say thank you for talking about this. I think that it's going to help all of us take the best care possible,
Thank you.
give you the best care possible.
I appreciate that.
So let's get that appointment set up.
Okay.
It's good to see you.